everyone. Thank you all for coming to our advocacy grand rounds tonight. And Noah's going to get us started.
Hi, everyone. Thank you so much, Elle. Before we get started, I just want to take a quick minute to thank you for joining and also invite you to officially join Doctors for America. Um, by being a Doctors for America member, it means you're going to take the important and simple step of selecting a membership level and paying annual membership dues to support DFA's organizational sustainability and incredible programs like tonight's Advocacy Grand Round series. There are 4 different levels to choose from, and a DFA team member is going to put the link to join in the chat so you can find it there. Just as a note, we're going to be recording tonight's session and making any material available afterwards. So a couple quick ground rules for tonight. First, there is no such thing as a stupid question. And speaking of questions, please remember to use the Q&A feature. We will address your questions during the second half of our session. And also look out for comments in the chat because DFA staff will be sharing some helpful links during the session. So now on to our speakers. We're thrilled to welcome Dr. Madeline Morcell, Dr. Ian Bett, and Dr. Megan O'Connell. As a quick note, Dr. O'Connell is experiencing some technical issues tonight, so she may or may not be joining us later. But as a quick intro to our speakers, Madeline T. Morcell, JD MPH, is a U.S. health policy attorney and strategist dedicated to advancing health equity and civil rights for low-income and underserved communities. As a senior attorney at the National Health Law Program, she leads efforts on non-discrimination in sexual and reproductive health care, health equity for people with disabilities, and closing the Medicaid expansion coverage gap. She also co-chairs the National Coalition for Gender Justice and Health Policy, which is a collaborative of over 60 organizations defending Medicaid, the Affordable Care Act, and civil rights. She previously held roles at the U.S. Centers for Medicare and Medicaid Services, the Mississippi Center for Justice, the Center for Public Health Law and Policy at Arizona State University's Sandra Day O'Connor College of Law, and the Network for Public Health Law. Also joining us tonight is Dr. Ian Bett. He's a family medicine physician practicing in a community health center in Lancaster, Ohio. And he's worked in healthcare advocacy since he was a medical student with AMSA, and now currently as a board member for the Committee to Protect Healthcare, and is a member of the Public Policy Committee for the Ohio Academy of Family Physicians. And last but not least, Dr. Megan Curry O'Connell is a board certified family physician and medical epidemiologist. Dr. O'Connell received her undergraduate degree in physics at Grinnell College and her medical and public health training at the University of Washington. After she completed residency in family medicine at North Colorado Family Medicine Residency, Dr. O'Connell practiced primary care in tribal and other underserved communities. She's worked with the Great Plains Tribal Leaders Health Board as part of the CDC Foundation COVID-19 Corps. And she was also a 2020 Bush Fellow and a 2022 Capello Health Advocacy Fellow. She's also very recently been named a 2025 recipient of the esteemed Healthcare Information and Management System Society Changemaker and Health Award, which is a global recognition that honors individuals who've made transformative contributions to advancing healthcare through information and technology. So a warm welcome to our amazing speakers. Before we hand it over to Elle and our speakers, I just want to provide a quick 2-minute primer to what we'll be talking about tonight. So public health is the set of laws, regulations, and practices that are designed to promote and protect community health through policies that intersect with individual rights and community well-being. So for example, smoke-free work policies. And these policies operate at local, state, and national levels to address health disparities, promote equity, and influence social determinants of health, including housing, education, and access to care. So key stakeholders guide the development of public health policies. For example, healthcare providers inform policy through research and advocacy. Community organizations drive grassroots initiatives and accountability, and government agencies develop and enforce policies. So, with our session tonight, we hope to learn from our panel of speakers how we as healthcare providers and community members can best influence and contribute to public health policy setting. And so with that, I'll hand it over to Elle and our panel of speakers.
Thank you so much, Noah, for that excellent introduction. And thank you, Madeline and Ian, for being with us tonight. So to get us started, we just thought it would be helpful to hear from each of you in your own words a little bit about your journey into health policy and advocacy and the current work you're doing. So Ian, maybe you could tell us a little bit to start?
Yeah, certainly happy to start, and thanks again for inviting me and having me. Hopefully we all learn quite a bit this evening, but I started in healthcare advocacy actually first as a patient. So a little over 20 years ago, I had finished graduate school, and before starting a full-time job, I had a several-month gap um, in terms of being employed and having insurance. Now, this is pre the Affordable Care Act being 20 years ago, and I had to make the decision as a young adult that I want to pay for the medication that I needed on a monthly basis, which was a fairly expensive inhaler at the time, commonly used and recognized. Advair is the trade name that people are familiar with. I had to decide, did I want to pay for that out of pocket, or living in Massachusetts at the time, did I want to pay for Cobra, which was the coverage that could be provided to me on a monthly basis, which was more expensive. And I made the decision to pay for the medication, not to get the full coverage, hoping that nothing else would happen to me, an ED visit, a hospitalization, some other catastrophic financial circumstance. And thankfully I got through that, and with only paying the several $100s for my insurance or for my medication, not for the insurance. And so when I decided to become a physician and go through medical school, and where I'm at now is recognizing that people make those decisions on a daily basis. That's why I've used a lot of my advocacy voice around universal healthcare for affordability and cost, not just for insurance, but for medications, because I have patients that make those decisions on a daily basis. And now I'm the person championed with teaching students and residents, myself, patients, colleagues, about how to navigate the system from an affordability standpoint, and particularly how I think a universal healthcare platform, which I'll reference later, a national health insurance, could provide that. So that's been the thread for over 20 years for me in all stages of pre and current life, is the ability to make sure that we can all have affordable healthcare and not need to make those sorts of really unnecessary trade-offs in our current society.
Thank you so much, Ian, for sharing that with us. Madeline, I'll turn it over to you.
Thanks, Elle. I ended up in health on policy because of my lived experiences navigating our healthcare system. It's a common tale for people in the health policy universe. I'm a woman with multiple disabilities, and as a result of those disabilities and other social factors, have lived experiences with coverage gaps, exorbitant out-of-pocket costs, and resulting medical debt on a low income. And in contrast, meaningful access to high quality and affordable coverage is a very early beneficiary of Medicaid expansion. I also have experience with things like intersectional sexism and ableism that delayed chronic condition diagnoses for roughly 3 decades from symptom onset. And that is an incredibly common timeline for women with disabilities to achieve diagnoses, and for underserved communities of every variety, particularly people of color. And I've learned a lot about what it means to have to care ration, to not be able to access the care you need, to not know what's wrong, and for providers to not believe you, to dismiss you because of who you are. And those experiences have been formative to my advocacy, but also experienced incredible healthcare providers who have really shown me what's possible if we can build a healthcare system that is free from discrimination and truly equitable. Earlier in my career, I held health law and policy positions in the federal government, started my career at CMS, the federal agency that governs Medicaid and Medicare, working to design and implement new healthcare payment and service delivery models with a focus on social determinants of health, health equity, and population health. Spent time as a community lawyer in Mississippi, working on access to public benefits, including Medicaid, and working on some broader public health law issues as well. And in 2020, I joined the National Health Law Program, where I currently work as a senior attorney. NHELP has advocated for equitable access to healthcare for low-income and underserved communities for over 55 years. And as a senior policy attorney at NHELP, I coordinate work on a range of healthcare equity issues. I also work really closely with the reproductive justice movement and intersecting movements on federal legislation and regulatory matters. And I guess all of those experiences have really fortified my belief that lived experience can be a superpower in health policy.
Thank you so much, Madeline, for sharing your story. And I'm delighted that Dr. Megan O'Connell can join us. Thank you so much for being here. We were just talking about each of your journeys into health policy and advocacy and the current work that you're doing. And congratulations on your award. Would you mind sharing with us a little bit about your journey to get us started?
Yes, thank you. First, thank you so much for having me and for everyone attending. And I greatly apologize for being late this evening, but happy to be here. So my name is Megan O'Connell. I'm the Chief Public Health Officer for the Great Plains Tribal Leaders Health Board. I'm a family doctor by training, and the Health Board is a consortium of 18 tribal communities across the Great Plains area, which is North Dakota, South Dakota, Nebraska, and Iowa. So I had a roundabout route to doing policy. I guess I do policy, even though I don't feel like that's what I do now. I am a family doctor. I trained in full scope family medicine. That's what I wanted to do. That's what I thought I would do forever. However, I did get an MPH in EPI in medical school and was exposed to some policy stuff through that training. But I thought I was going to be a clinic doc forever. But throughout my training and into my practice, once I was done with residency, I was always very cognizant of the policy things that impacted people's health. I'd always worked for tribes or the Indian Health Service, FQHCs. So things like Medicaid and payment and how much drugs cost were a part of every visit that I had, every single visit. It wasn't just some of them, it was every single one. It was front and center of my ability to provide care for people. And so it was just always in my day-to-day life. And it was always extraordinarily frustrating for me, and I hated it, and I felt like I couldn't do anything about it. After kind of a windy path, I was when the COVID pandemic started, there was the CDC Foundation, through funding through the CDC, had offered public health jurisdictions, all public health jurisdictions across the country were able to get up to 5 people to expand their staff. And I was living in South Dakota at the time and had worked with the health board, kind of volunteering. We were joining calls and just helping out with stuff. I mean, it was the pandemic and my clinical job was minimal, so I didn't kind of have a lot to do. And they were given this opportunity and had recently lost a medical epidemiologist who had retired. And so they created this position, and I applied and through the CDC Foundation and started working on the COVID pandemic. That's kind of how I shifted from, long way of saying how I shifted from clinical medicine to public health. That was in the fall of 2020. And I think my work in really going straight into policy had to do initially with data access. So the very first thing I learned within the first few days is the difficulty that tribal public health agencies have in accessing public health data. And so, of course, during the COVID-19 pandemic, needing to know who was infected, who needed vaccines, we didn't know any of that. And so a huge part of my job, because I had time, essentially, I was a new person, was to try to figure that out. And so I think that is how I started, transitioning into policy, having to dig more into these things about statutes and laws and how they work and what they mean, and how do you work with people to change that to improve, in this case, access to data. We've done other things around the syphilis epidemic, which I was working on today, that have to do with policy. And so that's kind of how I kind of feel like I fell into it. Happened to be there at the right time. But it definitely something I'd had an interest in for a long time.
Thank you so much for sharing with us. Now kind of shifting to some of the contact questions that we have. I think basic, just level setting to start, one of the questions that sometimes comes up is, how does health policy differ from public health policy? Is there even a difference between public health and healthcare policy? Madeline, you've worked across both spaces and are both a law and a public health expert. Can you speak to the relationship between public health and law and policy, and how these levers can be used to promote health equity?
Yeah, I mean, they overlap substantially. Public health law, healthcare law are both areas of health law, and there are certain issues that live in both spaces. So a lot of sort of concentric circles. Health law is a broad field that includes components of constitutional law, insurance law, civil rights law, privacy law. The public part is a lot of constitutional law in particular, and particularly the 10th Amendment concerning states' authority to promote the public's interest, but also includes those other things as well. And health law is really about the government's authority to act on our behalf to safeguard and promote the public's health at various scales. This includes multiple levels of government, federal, state, local, as well as individual and population level interventions, legal interventions. An example of the relationship between law and public health that I can offer is, and how this can help intervene in the social determinant space, is discrimination. So discrimination in our healthcare system is a profound social determinant of health and driver of inequities. Non-discrimination law is an area of civil rights law. It includes a number of federal laws. There are also some state laws that either enshrine similar protections or go above what federal law provides. And these laws provide a critical role in providing the public's health. For example, Section 1557 of the Affordable Care Act promotes the public's health by banning discrimination in healthcare on the basis of race, color, national origin, disability, age, and it was also the first federal law to ban healthcare discrimination on the basis of sex. The HHS Office for Civil Rights oversees implementation of federal non-discrimination laws in a healthcare context by issuing regulations that clarify statutory protections and investigating complaints and enforcing the law administratively when it finds that there have been violations. And in April of this year, OCR finalized a rule reinstating and expanding upon regulatory clarifications on protections against sex and intersectional discrimination that the first Trump administration rescinded. We successfully pushed the Biden administration to recognize for the first time ever in a rule on 1557 that obstetric violence, sex and other forms of discrimination in pain management, discrimination on the basis of marital status, discrimination based on gender identity and sex characteristics, including intersex traits, and the discriminatory denial of prescription drugs to manage chronic conditions on the basis of someone's capacity for pregnancy or perceived capacity for pregnancy, an issue we've seen a lot post-Dobbs, can all violate Section 1557. And the administration also added to the regs new clarifications around discrimination in language access, AI and algorithms, telehealth, and more. And recipients of federal funding, this includes everything from grants to federally funded insurance programs such as Medicaid and Medicare, have to comply with federal non-discrimination laws such as Section 1557. And OCR has done really phenomenal work over the last 4 years enforcing Section 1557. Just today, they announced a settlement agreement with Cedars-Sinai in LA. A couple of years ago, something that made national news was a Black woman, Kira Johnson, tragically lost her life after a routine C-section. And despite continuously raising pain and other really intense symptoms to her medical team, she was dismissed for over 10 hours and was allowed to hemorrhage before her surgical team took her complaint seriously and reopened her incision. She lost 70% of her circulating blood volume, about 5 liters, and she died on the operating table. And there are so many Kira Johnsons. Her widow, Charles Johnson, is not the only person who has filed complaints with OCR about discrimination in maternal care at Cedars-Sinai. And today, OCR announced a voluntary resolution agreement with the institution that includes agreements to implement early warning systems for timely recognition, diagnosis, and treatment for pregnant people developing critical illness, and other measures that are designed to prevent maternal morbidity and mortality, training on Section 1557 and the Civil Rights Act, non-discrimination protections, a new pain management protocol, and a new doula access program, among other really key interventions that will help ensure that her story does not keep repeating itself at this institution. And hopefully compliance attorneys at institutions around the country will also take note, and hopefully this will help set a precedent that will result in institutions taking obstetric violence more seriously as the crisis that it unfortunately is in the United States. But we know from Project 2025, the conservative movement's blueprint for the Trump administration, that the new rule on Section 1557 that was finalized last April is likely to be on the chopping block for the second Trump administration. And it's also true that regardless of what happens to the regs, the underlying law, barring changes to the statute by Congress, continues to be the law of the land, and enforcement in the courts still remains possible. So we at the National Health Law Program, as well as our advocacy colleagues around the country, will hold the line on as much as we can for as long as we can on non-discrimination protections, and will continue to enforce the law as appropriate in the courts.
Thank you, Madeline. I think that's something that we all probably can empathize with is filling in public health law and policy that often when it comes to the social determinants of health and non-discrimination, we take 2 steps forward and then 1 step back. And that when it comes to the incoming administration, how far back we'll go is definitely of great concern, especially when we think about the social determinants of health, their stance on DEI and health spaces. And one of the concerns that has come out of this among public health experts is the extent to which our advocacy efforts and energy is going to be consumed by just defending the basic tenets of public health, such as vaccine access or non-discrimination in healthcare, which should be a basic tenet of public health. Megan, I'm going to turn this question to you to start. Are there approaches that you've found in your work to focus and promote health equity and social determinants of health in your advocacy for healthcare that you found are particularly helpful as you combat these like multiple competing interests in your strategies?
Yeah, it's I think my position is a little bit different than a lot of people's because I work for a tribal organization. So I see everything we do as addressing health equity, right? So it's not just a particular part of my job or my organization, where we are run by the tribes. Tribal leaders are my bosses. And so everything we do is works to improve the health of Native people across our region. So I would encourage you to work for organizations like mine if you're interested, because if you really want to center equity, doing it from an organization that's structured like mine is one way to do that. But of course, not everybody can be quite as lucky as I am, and so, but I think. I find this question very interesting, so I hope that I can explain what I'm thinking here is when I think about social determinants of health or equity, those are the most basic tenets of public health, right? If you like, it doesn't matter if vaccines are technically available if they're not being distributed to everyone, right? Or if you're working with a community that can't get them, or you can't get them because you don't have insurance. So I don't really see them as separate. You have to, in my opinion, I don't know what we're doing if we're not centering those things, right? Because again, you can have all the fancy, most innovative medical stuff in the world, which we do in this country. But if you can't access it, it doesn't matter. And it for whatever reason, because I don't have a car, because I don't have insurance, because I don't have enough money, because I don't have a babysitter, because they won't see my race, or I'm discriminated, like whatever those things are, those are the most basic precepts of public health. And I don't think they're separate, and you can't disentangle them from just vaccine access means vaccines for everybody, despite what social determinants of health or discrimination those groups may face. And so that's how I've always approached my work. They're not different. That's like the core of what you have to do. And I will also just add, like, making sure, for example, that everyone can actually get a vaccine, right? They have to be available, and then you have to be able to give them to everybody, and people have to be able to access them. Will do more for people's health than having access to AI, read radiology films or something. And so those really basic fundamental public health activities, if we ensure that they're available to everyone, and that, to me, that addresses like all concerns about discrimination and social determinants of health and financing, right? If we make sure those are available to everyone as our goal, we are doing public health, and we're doing the most good for everyone.
Thank you, Megan. I wholeheartedly agree and deeply appreciate your answer. When we think about equitable reforms within public health and health policy, I think all of us have seen examples where approaches that are meant to increase or enhance equity sometimes can have unintended harms and consequences that can actually undermine our effort or lead to less equitable outcomes in the long run. Engaging key stakeholders is one of the key aspects to try to help ensure that we're promoting equitable healthcare and reducing those unintended harms. And I'm going to direct this to you. Who are some of the key stakeholders that we should be thinking about engaging in our advocacy work? And how do we identify and build these collaborations with those stakeholders?
Yeah, I think you have to put patients first in all of these circumstances. We're all going to be a patient at some point in time, or have been a patient, currently are a patient. So I think engaging with the people that we're meant to be serving primarily is just a good place to start. Then you can talk about the physicians, then you can talk about the health systems. If you don't talk to the patients, who end up being yourselves or your neighbors, your family members, your other community members, if you don't talk to them about what's going to help them most, and it doesn't have to line up exactly with what they think is going to be helpful. This is how our experience can be an aid to them. But a lot of times they have the ideas that actually will improve their day-to-day existence. And just like Dr. O'Connell was saying, the social determinants of health, my perspective on that is we need to make it so that there aren't any social determinants of health. As I said in my introduction, my purpose, I think, in being on this panel and in my advocacy is about universal health care. And if we engage from that platform that everybody deserves health care when they need it, how they need it, and who they need it from, and we engage each other, maybe we have specific interests as clinicians or researchers or even as patients, but we go to the other people who are engaging with healthcare issues, whether it's diabetes, whether it's women's health, whether it's behavioral health, going to those other organizations, other doctors, other groups, and saying, how can we work together to get the common goal where people have access to care when they need it, how they need it, everybody gets it. That's where my mind goes with that question. I'm not sure if other people want to comment on that.
I mean, I would just echo the people closest to the problems are often closest to the solutions.
I just want to highlight something you said at the very beginning that just triggered something for me in terms of putting the patients first, which I think as physicians, we just do that. That's what we're supposed to do, right? Like all of your training, your whole career is about, you put away your sleep and your nights and having to go to the bathroom and holidays and your kids' birthdays, right? It's all about that, whatever the person is in front of you needs, it's our job to get it to them. And it was very surprising to me when I kind of moved out of clinical land into public health and policy. But having people that have that perspective in the room is really important. So I spend a lot of time going, okay, but we've got to treat people for syphilis. Like that's all I care about, right? Remember that this is the thing that we're trying to do. And I think having that clinical perspective where you're maybe shifting, I don't have an individual patient, I'm trying to treat people on a broader scale, whether it's through a policy or through a public health intervention, but really you're still just a doctor that's trying to make people well, and bringing that perspective into these conversations is really important because not everybody, I think they have it. I don't want to say they don't have it. Everybody that works in these spaces, cares about patients and people, but it's not quite ingrained in them, I think, as it is in clinicians. And they don't always think about it the same way we do. So if you're interested in policy, I think that's it doesn't seem unique to us, at least it didn't to me when I first moved into policy, but it really is a unique voice that you can bring as a clinician to say, okay, these are our patients. This is what we have to do for them. That's what we're here to do. How are we going to figure it out? Just as you would with an individual patient.
Yeah, and Megan, building off of that, I I know that one of the challenges that was really highlighted by the COVID pandemic, in particular among tribal communities, is that often tribal populations are excluded from the data that are used to inform health policies, or when they are included, often don't even have access to the federal data that's being collected around their communities. And so this can result in policies at the federal level or at other levels that conflict with the public health interests of the communities or fail to represent the needs of your patients and communities. How have you navigated these times? And if you have an example, I imagine the current syphilis epidemic that you were talking about, probably you've met some of those challenges.
Yeah, I don't think we have enough time to talk about all the data challenges that we face, but if anybody's interested, I'm happy to talk to you. But you're right. There are a lot of issues with data in public health, which therefore policy that even despite having my MPH, despite responding to public health outbreaks as a physician, despite, having all this extra training and experience, I did not have any idea of the scope of the issues till I moved fully into public health and people were asking me things like, what is the COVID rate in our community? And I couldn't tell them. And so there's huge gaps, especially for Native communities, which I can speak the most about, but generally speaking in public health world, there's a lot of challenges with data and then being used to formulate policies. I think one of the ones that comes up a lot for us and is something that I'm hoping we'll be able to somehow improve has to do with maternal health, just as an example that we work with all the time. There is some limited data out there about the access to maternal care for American Indians and Alaska Natives and their outcomes. So for example, the March of Dimes has put out reports the last few years that are called maternity care deserts. Our states are always the top states for the most deserts: North Dakota, South Dakota, Nebraska. In terms of the number of women that they have to travel the farthest, the number of counties that don't have any maternal care. But nationally, even the rate of maternal mortality among American Indians and Alaska Natives is not published. The CDC does not publish that. So if you Google U.S. maternal mortality rate, CDC, there is one paper they did recently, but their yearly updates do not include American Indians and Alaska Natives. And there's reasons for that, again, if you're interested, I'm happy to talk with you. But that means we don't know what it is. We literally don't know what it is, right? And that's for a whole country, right? There's more American Indians in the whole country than there are in the states of North and South Dakota combined, for example. Yet the states of North and South Dakota can have maternal mortality rates, but we can't get one for the whole country for American Indians for concerns about the collection of race and small numbers and all these things. But that means that, again, Google it. You guys can prove me wrong. If you start to look for articles about maternal mortality or where the funding is going for maternal mortality, American Indians just aren't there. Occasionally it'll pop up, but they're not there because they've literally been removed from the initial data that's spurring these conversations. So we have an idea that from the limited data available that the maternal mortality rates in American Indian and Alaska Native communities are quite high. But we can't prove it and it's not talked about. And so solutions to address the unique needs of those communities, to address what we assume to be the high rates of maternal mortality in the communities, it's very, very, very hard to do. So for this particular issue, as an example, I think one of the things is trying to figure it out, right? If you have the means, and there are ways to do this, like get what you can and try to figure out what it is from whatever means possible or whatever data you're trying to do. If you're working with these communities, whether they're native or not, I think you have to be a really good data sleuth. You have to have really good numbers sense. You have to kind of be able to look at something and squint at it and make good estimations about what data is publicly available while you work through policy efforts to improve it, either through improving the quality or improving the access or improving the release. Most of the time, the data needed to do these things exists somewhere. It's just not published or it's not freely shared. It's not that nobody knows that an American Indian mother died, for example. It's just that, again, it's maybe not shared, it's not widely disseminated, or it's not released. So we do work a lot on that. I do a lot of work around data access and trying to expand what's available because you can't address what you don't know is going on. And getting funding, so again, from the policy side, getting funding is extremely difficult if you can't prove that there's a problem, right? Because funding sources like the federal government want to know what are your syphilis rates, what are your maternal mortality rates, and how are you going to make them better? If you can't tell them what those are, you're not even going to be able to get funding to address the challenges in these communities.
Thanks, Megan. And I think that parlays us well into the conversation around economic burden associated with public health and health policy reform. And so one frequent critique of public health reforms is the economic burden that it may place on governments or on communities. So our question is, how can physicians and advocates effectively push back and argue for interventions in the face of these economic arguments? And I'm going to direct this to Madeline, if you can talk a bit about how you address this in your advocacy, especially right now as Congress is considering Medicaid cuts.
Sure. I mean, we can explore this through the lens of Medicaid, the country's safety net insurance program that currently serves over 72 million people with low incomes pretty easily. Medicaid does critical work for protecting and promoting the public's health as the primary insurer of people with disabilities, source of coverage for roughly 1 in 5 women in the United States, and a major source of coverage for people of color. The primary payer of services in the US, such as long-term care of supports, pregnancy care and family planning, services such as contraception, and expanding eligibility, such as through Medicaid expansion, has reduced preventable mortality and morbidity rates and narrowed racial and other health inequities around the country. In contrast, barriers such as state refusals to expand Medicaid, immigrant eligibility restrictions have been major challenges in the struggle to end our maternal mortality crisis, our Southern HIV epidemic, and so many public health crises. Right now, President-elect Trump and his allies in Congress are considering various options to cut Medicaid in their 2025 reconciliation package, such as passing work requirements, block granting the program, changing the funding structure to per capita caps, or disincentivizing Medicaid expansion to get states to unwind that eligibility for that group. And each of these options would operate as a massive funding cut that would result in millions, if not tens of millions of Americans losing access to health coverage and care. But what about taxpayer dollars? We know from experience, decades of experience in other public benefit programs, as well as specific experience with work requirement implementation in some states in a Medicaid context in particular, that things like work requirements are just severe Medicaid cuts by another name. Research demonstrates that most working age Medicaid enrollees work. Nearly all those who do not work cannot. because of disabilities, serious health conditions, childcare, caregiving responsibilities, or because they're students. And studies show that work requirements and safety net programs create burdensome and confusing red tape, paperwork, and reporting requirements that result in sweeping eligibility losses, including for low-wage workers. For example, right now, under the country's only Medicaid work requirements program currently in operation, it was approved by the Trump administration, Georgia's Pathways to Coverage Medicaid work requirement program, only 5,500 of the 300,000 low-income Georgians who should have gained coverage through Medicaid expansion coverage have actually been able to do so. And ironically, work requirements don't improve employment outcomes, and administration costs a ton of money. Work requirements, if they were implemented on a national level, the Congressional Budget Office has estimated a couple years ago, when the last time we had this conversation as a country, that about 15 million people around the country would be subject to them. Many may technically qualify for exemptions based on disability, for example, but we know from experience that exemptions don't work. And people who should qualify still get cut out of the program. And work requirements would leave millions of people ineligible for Medicaid coverage. CBO estimated that some states would cover the cost of maintaining coverage for those individuals, and it would cost states about $65 billion between 2023, because this was from a couple years ago. In 2033, there was the remaining 40% would lose coverage. We also know that implementing work requirements costs state economies. We know that by cutting off access to healthcare, work requirements make it harder for low-wage workers to stay employed, threatening their economic security as well as the stability of the workforce. So really the argument that Medicaid is an economic bad deal just doesn't hold weight when we look at the evidence, decades and decades of evidence, both in Medicaid and SNAP and TANF, where there have been mandatory work requirements since 1996.
Thanks, Madeline. We are nearing the end of the hour, and we have some great questions from the audience. This has been such a rich discussion. We had so many more questions that we want to ask, but I want to make sure that we have time for audience questions, so I'm going to turn to those now. The first is from Lisa Plymate, who asked, another group of patients that are at risk for losing their current health care under the incoming administration that's often not mentioned under the rubric of public health are veterans. And it's a system that's highly likely to be dismantled. Is anyone looking at how this massive, mostly poor, often medically complex patients could be added to our overtaxed healthcare system? For example, the 15,000 men with metastatic prostate cancer who would need new doctors.
I mean, I will say there are groups that specifically look at the VA system and serving veterans. The National Health Law Program primarily focuses on Medicaid, and so this is about a bit beyond me. But certainly, if our VA system went away, if Congress defunded or substantially cut funding for IHS or federally qualified health centers, yes, that would create a huge gap in what is already a patchwork quilt healthcare system.
On the topic of federally qualified health centers, Jim Barry, a first-year medical student who's interested in family medicine, asked that he would like to return to his hometown, which is in a very rural area, once he finishes his training. He's not thrilled about working in a federally qualified health center where he may be expected to do the work of 2 or 3 physicians. How can policy leaders make working in these rural areas and in these health centers more desirable to physicians?
I mean, I can take an initial step, but also happy to defer to someone else. first with experience. Ian?
Sure. I appreciate the question because I started my career in a larger academic system and have been practicing in a federally qualified health center just for the last 2 years. And if you're considering family medicine, the American Academy of Family Physicians says we're the heart of medicine, which I agree with. And the heart of the community is the federally qualified health center. It's actually a really exciting place to work. If you're considering doing that type of work after residency or even training, I have residents that train with me in a federally qualified health center. Go there and you'll be amazed at how it is the hub of the community. And being a physician is tough, I think, no matter what specialty you choose, no matter where you go. But I've had a lot of fulfilling experiences as a physician, and at least as many in the last 2 years as I did in the 7 or 8 years before that. And not because I didn't have really great experiences before, but just because there's so much more robustness when you're in a smaller community that the work is going to be laborious no matter where you practice, but it's doable, and that's part of training. So I encourage you to look into it, even as a student. The energy in a federally qualified health center is very different than anywhere else you're going to encounter clinical practice.
And I would just say, as a non-clinician, FQHCs have roots in the civil rights movement. They truly are the heart of communities. And if you have concerns about the capacity of FQHC physicians, providers, and staff, like, talk to your elected officials, because this is an appropriations issue. Your members of Congress need to hear from you that FQHCs are dramatically underfunded relative to the need. And with adequate funding, caseload issues wouldn't be what they are. We need to invest more in our public health care safety net, and FQHCs are the heart of that. So your electeds need to hear from you that you have a strong interest in this work, and the inadequate appropriations are keeping you from, are making you feel concerned about that path.
Thank you both. Dr. Eric Fetke had 2 questions in the chat. I'm going to take a second one first, which is, do we see the implementation of a centralized open EHR system, open electronic healthcare health record system with a common health database and only one lifetime medical number identifier for each individual as a solution to some of the health data issues?
So you can comment on some of the data stuff. I mean, that would be great. I don't see it happening anytime soon. I know it's been tried before and was resoundingly rejected, even though everybody thinks that EHRs all talk to each other. They obviously don't. But there is a lot of, from the public health side of things, there is a huge push because of the COVID-19 pandemic to quote unquote modernize the health data systems throughout the United States and get them to talk to each other better. So while it's won't be exactly what you proposed in your question, there is funding, and there has been funding appropriated, and a bunch of programs through the CDC primarily leading these efforts, but other federal agencies are involved to essentially try to weave these different systems together, both from the electronic health record side, right, through things like electronic case reports or ECRs, which were rolled out with COVID cases during the pandemic, and also through trying to combine all these systems so that they can talk to each other. So definitely, I think public health is trying to figure out how to take this very patchwork, disparate system we have where go try to get HIV data from the CDC. It lives in like 4 different departments and they don't all have the same data. So like that doesn't happen anymore, that it works like we all think it does, but it doesn't actually work. And if that occurs, there is kind of bi-directional flow from, you know, clinical to public health and back, and from that way in between clinics. So I do think there's potential hope to improve communication through EHRs between clinical facilities, which are doing it pretty well compared to even a few years ago, and also include public health, but it won't quite be like a universal EHR system where we all, you know, we all have a number. But there's definitely a lot of movement right now to make it better than it is, and definitely a lot of room for improvement.
Awesome, thank you. I'm going to move to Leslie Grubel's question. She prefaces this that she's in Florida, and their attempt to reverse the 6-week abortion ban was approved by 57% of our voters, but it has to be 60% to pass. I think we all watched that very close vote with bated breath. And not to mention attempts to pass Medicaid expansion, one of 9 states that don't utilize this federal funding. They're seeking an amendment petition for expansion on the 2026 ballot, and concerned that Florida is an example of regressive policies in some of these regards. Are there any efforts to coordinate data on maternal or infant mortality in relation to the impact on abortion restrictions?
Yeah, so this is a huge issue right now in the sexual and reproductive health rights and justice space. Maternal mortality review committees are multidisciplinary groups that convene at the state or local level to review deaths that occur within 1 year of pregnancy. And CDC works with maternal mortality review committees around the country to improve review processes and report on findings. In November of last year, Georgia officials dismissed all 32 members of the state's maternal mortality review committee after investigative reporters used internal committee documents to link the death of 2 women in Georgia to the state's 6-week abortion ban. So there are efforts to link abortion bans and increasing maternal mortality, and they're being suppressed by state elected officials. And we're very concerned that very soon they're going to be federally suppressed as well. The nominee for the U.S. Centers for Disease Control and Prevention, the CDC is Dr. Weldon, who is a former U.S. Senator for Florida and is responsible for the Weldon Amendment, which is a really discriminatory policy that has to do with abortion-related discrimination and is going to be in charge of running our country's public health agency. And there is a proposal in Project 2025 to weaponize the CDC's abortion surveillance program and collect misinformation on abortion-related fatalities, which is a non-issue. Abortion is a safe and effective healthcare procedure, and require states to report that misinfo or lose their federal Medicaid funds for family planning. So this is a huge issue, and unfortunately, I think we're likely to see a lot of traction on it very soon.
Thank you, Madeline. We have one last question from Eric in the chat on improving access to medications for through 340B to make sure they're not abused by profiteers. I'm going to ask if anyone has an answer to this that they would like to put in the chat, just for the interest of time. Otherwise, I was just going to move to our final question so that we can get everyone out on time. Hopefully, give you back a little bit of your night so you have some time to call your legislators with some of the topics we discussed tonight. And so that question is, if each of you could tell us just one thing that you think every doctor or health advocate should know about health policy as we move forward in our careers. I'm going to start with Ian.
Yeah, thank you for that question. I think the thing and I hope I don't steal anyone else's idea here, is to get involved. It doesn't matter where you are in your training, how old you are, how young you are, what you're doing. Get involved, whether that's just as a community member, not using your medical expertise or legal expertise. Go and testify on something that you think is important to you or your community. Talk to the legislator like you're going to do after this call. Talk to your physician. Talk to people that are involved in healthcare. No voice is too small or unimportant. We all got started somewhere. It may not be something that you do on a routine basis, but if there's a topic that's of interest to you, use your voice, connect with other people. That is how movements start, and that's how they continue, and that's how they win.
Madeline?
I mean, super similar message. We're entering a tumultuous moment in US history. I think we're in another period of civil rights backlash akin to what we saw post Reconstruction, and that's a really scary possibility to sit with. Your members of Congress and your state elected officials need to hear from you about the importance of protecting the public's health, and whether this is about protecting Medicaid access to care for over 72 million low-income and disproportionately underserved individuals, or on the dangers of someone like Dr. Weldon running CDC, or RFK Jr. running HHS as a peddler of misinformation, or Dr. Oz, another peddler of misinformation, running the Centers for Medicaid and Medicaid Services. They need to hear from physicians. Your voice is so important.
Thanks, Madeline. And lastly, Megan.
Sure. I think you should know, which I assume everyone on this call does, but the things you like and don't like about being a doctor or treating your patients probably have their roots in health policy. So you can't separate your day-to-day work in treating patients from policy. I think that, I entered med school 20 years ago now, and maybe before you could do that a little bit more. But now, I think everybody's just more aware of how all these policies are impacting our work as physicians and our ability to care for patients. And so, again, I'm probably preaching to the choir, but I don't think physicians can pretend that there's some sort of disconnect between health policy and writing prescriptions. There's a direct link between those. So that's what I would like you to know. And then kind of my advice, as I agree with what was said before, but I would just add, never give up. The goal of this game is to outlast. You have to outlast whatever barriers are put in front of you, no matter how many times you have to bang your head against them, no matter how many times you make them fall and they come back up. The key to being successful is you cannot give up. And so where you get that drive, it's probably different for everybody. It's different for me than for you. So if it's something you care about, or people you care about, a place you care about, your hometown, whatever that is that will give you that drive, I think it's really one of the most important things is you can't give up. It's not an easy, doing policy and making big policy changes is not easy. And it can be extremely frustrating and disheartening sometimes. But the way you get things to be the way you want them to be is you just never give up.
Thank you so much, all of you, for this just incredible insight and this really, really wonderful discussion. I just want to wrap up with just a few, I guess, kind of summary highlight key points that I think kind of stood out during tonight's session. And I think those would be that we as a clinicians really do bring a unique perspective and a voice that we can harness to more effectively inform health policies. And at the same time, we're also patients, and we can draw on that too to inspire us to drive the change we seek. And when doing so, we should put patients first, whether that's they're looking at their lived experience to get insights into what the issues are or should be a priority, or just understanding what is going on that we may not even know about, because that's kind of the first step to making change happen. But most importantly would just be getting out there and talking to elected officials and also other stakeholders, to everybody is kind of, I think, the message I heard here tonight. So again, thank you so much, everybody, to our speakers and also to our audience. I'll just close this session with a couple last reminders. Please look out for any additional opportunities to give input on future policy issues, including those of you who are paid sustaining members of Doctors for America. You can complete the survey for CME credit for attending this session. And if you enjoyed this advocacy grand round session, please do consider supporting DFA's work and impact with a financial gift. One of our moderators will put the link to donate in the chat. So again, thank you for being here and for all you do on behalf of patients. We hope you will become an official DFA member today if you aren't already. And yeah, have a really great night. Continue to advocate and go call your legislators tonight.